Hello, dear colleagues. Let me introduce the newest case. This is not my personal case, but it is very interesting case that happened in our clinic. And let's start from the patient demographics. And he was male and 67 years old. He's admitted to our hospital with chest pain, and ECG was unremarkable. Old Q waves due to previous anterior myocardial infarction. Troponin T was elevated 0.26, and if we talk about anamnesis, previously, as I mentioned, he has anterior STEMI, and that's why he underwent stenting for proximal LAD lesion. And if you talk about risk factors, he is smoking more than for the 60 years, and he had diabetes mellitus as well. That's why cath lab was activated. And if you look about basal angiogram, you can see different lesions in different arteries, and you can see subtotal lesion in LAD, ostial lesion of left main, occluded RCA, and some kind of lesion in circumflex. You can see different projections to assess the complexity. Lateral projection as well is showing us about the moderately impaired flow in LED and proximally occluded RCA as well. You can see. So if you talk about complexity of the disease, you can see three kind of lesions that we bump into. So first, it was a bifurcation lesion in mid LAD, 0.1.0 if you talk about Medina classification. Second, however, we have the in-stent stenosis, or kind of underexpansion of stent implanted in the proximal part of LAD, and as well we have the ostial disease of left main. And what the best strategy of treatment of the patient? First, maybe we should do isolated mid-LAD bifurcation stenting, provisional or crossover, something like that. Stenting of mid to proximal LAD with provisional approach in mid segment, crossover stenting and mid to proximal LAD, crossover left main stent and proximal optimization of left main stent, provisional LAD bifurcation stenting of proximal LAD, and provisional left main stent. So we decided to do second option, stenting of mid to proximal LAD with provisional approach in the mid segment, but we bump into some problems. First, you can see the balloon angioplasty, some kind of underexpansion of the balloon in distal to mid segment of LAD, and you can see how deep in our guide was engaged into the LAD, and it seems that it touches to the previously implanted stent. After plastic, the flow was restored. You can see the longevity of the disease, and stent was implanted directly. However, directly some kind of preparation was performed, but it seems that it was not sufficient because during the implantation you can see kind of under expansion of the stent in the mid portion, and but I would like to I have some remarks regarding the coordinate artery segmentation rules, because we have practically at this moment two classification: syntax 15 to 16 segments model, or Cas-Barre model with 30 segments. And generally in our practice we use first one, I mean 50 to 60 segments model, and due to this model, the mid segment of LAD is located between the first perforator and so-called angle of LAD, which is generally can be identified in raw projections in raw view, and if angle is not exist, this segment ends at 1/2 distance from the first perforator and apex of the heart. And so that's why we implanted our stent, however, in the distal segment. But what the wrong with the next step? And in this angio, you can see the kind of material in the proximal LED and left main, and practically it was the stent which we can't deliver to these lesions because I don't know, maybe due to inappropriate preparation of the vessel, maybe due to our manipulations with guide catheter which engaged too deep and damaged proximal struts of the previously implanted stent, I mean stent of proximal ID. And you can see the dislocated stent from the balloon stent. So this algorithm was presented by Manos Brelakis, and practically we have three main options of the stent retrieval. First, the usage of loop snare. Unfortunately, we didn't have small loops at this moment, and small balloon technique may be used because it is very easy to use, and smaller balloon can cross through the stent and can be inflated and withdrawn with all wall system. And guide wire twirling technique, it is as well a very common thing which can be done practically. And we tried to use guide wire twirling, but it was unsuccessful, and wires was going out without the stent removal. Unfortunately, we tried to use small balloon as well, but it was too long and it can't pass through the stent. And we hadn't any other options with and only crushing, and this situation was possible, I think. And we crossed with the over the wire balloon. It was 220 balloon, and it was inflated somehow in different segments. And after that, 30 balloon was delivered. It was very difficult to deliver any balloon through this kind of lesions and stent, which we lost. And we did kind of preparation to the whole length of the vessel. And after that, you can see that we were able to deliver our stent in mid to proximal LED, and then we positioned left main stent. And what was the mistake there? However, I think we tried to implant it too close to ostium of the left main, and during positioning it was under recognized that our stent goes too proximal to previously implanted stent, and we bump into this situation. You can see that our last implanted stent is um, kind of opposed of the LED, and it is I don't know how to describe it properly, because you can see in coaxial not coaxial alignment of the stents, previously implanted stent of LED. I mean, this is a stent which was implanted in 2005, and our current stent. And what to do in this situation? However, there is no option. Only one option can be done. It's to implant one more stent. And you can see the ballooning and implantation of the stent. This is not perfect case, I think, and operator is not performed kissing balloon angioplastic and proximal optimization, and it is not perfect again. And but in this situation, it was only the decision to do kind of caging of the um, previously lost stand, and however, it is not so bad decision. But again, I should say that life is not always perfect, and this case is illustrating this suggestion. And why is that happened? The main thing that we should think about is the causes of this problem and this complication. First case, and however, it's tortuosity and calcification, and of course the lesion should be prepared very well before implantation of our devices. Stent delivery through another stent, it is always kind of complicated thing, and we should do it very accurate, and not so quick, and trying to do it very delicate. And we always should use a good support with not so small guides, and small guides can sometimes can release the stent from the balloon when we try to withdraw it. And we shouldn't do the forceful withdrawal stent as well, and sometimes it is a good option to use the guide extension, like GuideZilla or GuideLiner and something like that. And retrograde delivery through collaterals can be applied, but it's very exotic option at this moment. And I should say that this picture illustrates that we should be very delicate with our guide catheters, and we shouldn't do it like that. We shouldn't try to quick removal of our balloons, because our guides can move towards to the artery, and can damage something, can damage artery, can damage previously implanted stent, and make our further actions very difficult. Prevention. We should avoid direct stenting. We should prepare our vessel. We should stent from distal to the proximal, and sometimes we should use guide extension and avoid a very forceful pushing. And we should avoid any resistance, and stop when it happens, and avoid small guides, and use good guide supports, and maybe use larger guides. And you should always inspect stents um, if you observe that you have some resistance during its delivery.